people a chance to sit down.
Are you still at the plan? You still at the plan? How's it going?
Welcome to the ARCO Forum at the John F. Kennedy School of Government for another in our series of forums on issues in healthcare reform. This forum is sponsored by the Malcolm Weiner Center for Social Policy and the Institute of Politics at the Kennedy School. I'm Julie Wilson, Director of the Malcolm Weiner Center for Social Policy. We've seen in our forums to date that there are enormous questions about how to finance healthcare reform, what to do about the rapidly growing cost of an industry that now consumes 15% almost of our gross domestic product, and how healthcare will be organized, how we as individual consumers will get access to the healthcare that we need. We're going to continue this discussion tonight in a somewhat different format than we've used before. We're going to have one main speaker, Alan Enthoven, who will deliver a longer address than normal, and two respondents, Deborah Stone and Charlie Baker Jr. Alan Enthoven is the Mariner S. Eccles Professor of Public and Private Management in the Graduate School of Business at Stanford University. He holds a degree in economics from Stanford, where he was a classmate of Derek Box, and from Oxford, where he was a Rhodes Scholar, and a PhD from MIT. Professor Enthoven is in the typical Kennedy School mold in that he's held jobs in all sectors possible. He's been in government, the private sector, and the not-for-profit sector. As an economist at the RAND Corporation, as president of Litton Medical Products, and Assistant Secretary of Defense. In 1963, he received the President's Award for Distinguished Federal Civil Service from John F. Kennedy. In 1977, while serving as a consultant for the Department of Health and Human Services under Secretary Califano in the Carter administration, Enthoven designed a plan for universal health insurance based on managed competition in the private sector. Along with Paul Elwood, known to us as David's father, and Lynn Etheridge, Professor Enthoven is author of the Jackson Hole Group's Managed Competition Plan, and his most recent book is Theory and Practice of Managed Competition in Healthcare Finance. If I were Ed McMahon, I would be standing here saying, "Here comes Mr. Managed Competition." But I'm not, so may I present Professor Alan Enthoven.
Thank you very much. I'm very pleased to be able to be here. I particularly value my experience in the Kennedy administration, and so I'm very happy to have this brief association with the Kennedy School. It's been a pleasure here to see many friends of long standing. And perhaps most important about Harvard that I think of is this is where I found my wife, now of 39 years of blissful marriage. I'm going to start talking a little bit about market forces in healthcare. And when I do that, people say, market forces, what does that have to do with healthcare? And how do we know that would work? And I want to begin by reminding you, if you have that question on your mind, that in this century, around the world, we have seen a worldwide contest between two ideas about how to organize economic activity. One that we call decentralized private markets, that we associate with Margaret Thatcher and others, competition, in fact, that we associate with Adam Smith in 1776. And the other is centralized government planning, that is, resources allocated by decisions made by the central government. And the interesting thing about this contest is that in recent years we've seen that there was an absolutely clear winner. That is, socialism, central government planning and controlling of the economy, utterly failed wherever tried. And so now countries that did believe in government central planning and control are struggling to convert to market economies. One of the most interesting experiences that I've had in recent months is in November I was keynote speaker at an international meeting in Rotterdam where people from different countries were sharing experiences in trying to introduce managed competition, as they are in Great Britain and in the Netherlands and in more halting ways in other countries. But in a way, I found by far the most interesting paper was one by Igor Shaiman of the Academy of Sciences of Russia, who described a managed competition experiment now being run in Russia, where competing insurance companies each get a capitation payment and they compete for subscribers by quality of care. Dr. Scheinman explained to me, we only spend 3% of GDP on healthcare, so it's not as if we're looking to competition to reduce the costs. What we are looking for is competition to improve the quality. We need somebody to sort out who are good and bad doctors, because we have an enormous amount of appallingly bad quality care. And also we would like to use market forces and market prices in order to eliminate the corruption. Because under the socialized system where the doctors were underpaid, of course there were a lot of under-the-table payments in order for people to get medical care. Now, with the broad background that market economies have stimulated innovation, progress, made life better for the workers, let me focus on the Jackson Hole vision for a reformed healthcare system in the United States. It's based on 5 main ideas. The first is that there must be universal coverage, financed for the most part by people paying their premiums, so that they're seeking value for money and they're connected with the services that they're buying, and with subsidies for the poor, for those people who can't afford to pay those premiums. Secondly, that coverage should be channeled through what we call accountable health plans, that is, integrated financing and delivery systems that link doctors, hospitals, and insurers. Third, that those accountable health plans should be placed in a framework that we called managed value for money competition, where informed, cost-conscious consumers have choices of health plan, an annual enrollment in which they can switch from plan A to plan B if they're not happy with plan A or B, and in which all of those health plans are under strong market incentives to improve the quality and cut the cost of care. Fourth, we need pooled purchasing arrangements for people in small employment groups and freestanding individuals, because small employment groups are too small to spread risks, to achieve economies of scale and administration, and to offer multiple choice of health plan to members of their group. And fifth, no market can work satisfactorily without some boundaries and ground rules to set the boundaries and to focus it on serving the public interest. I think of, for example, the securities markets, which you might think as being the stock market as being the ultimate free market, but in fact there's a lot of securities law and regulation. We have the Securities and Exchange Commission, founded by President Kennedy's father. There are a lot of rules about how and when and under what circumstances you can trade securities and so forth. And similarly, I'd say in healthcare, we need to have a regulatory framework that would facilitate competition, which we call a national health board. Now let me come back to the first idea, universal health insurance. The Jackson Hole Group, the main authors of which are Paul Elwood, David's father, and myself, but which we've developed over the years, consultation with a number of leaders in the healthcare industry, policy analysts and others, believes that we must move to universal health insurance, and that somehow we need to combine, to finance it, individual and employer mandates with subsidies for coverage for those people whose incomes are too low for them to be reasonably expected to pay for it, that there should be no free riders, that is nobody, because if somebody is seriously ill or injured and doesn't have coverage, then what happens is the rest of us who paid our premiums and paid our taxes have to pay for that person, for that person's care, because we don't let them just die out in the streets. And that we ought to keep coverage in the private sector to the extent possible because of the flexibility, the adaptability to customer needs that you get in the private sector. Now, the heart of the story here is the following: that the traditional fee-for-service, solo practice, remote third-party payment model that was the dominant model from World War II until recent times has failed us, has been an economic failure, has made healthcare cost way too much, and has not promoted quality systematically for a number of reasons. Primarily, that the incentives are mostly wrong. As the physicians here know, there are very wide variations in the ways that different doctors, well-qualified doctors, will treat the same patient to produce about the same outcome. My very good friend and former student David Chin, in his time as Harvard Community Health Plan president, instituted practice pattern studies in which they'd study variations. He was recently out talking to some of our doctors and saying they found within Harvard Community Health Plan, the same setting, 85% Harvard-trained doctors, so they couldn't be all bad, that, I mean, it's not Stanford, but it's, they're okay. They found 5 and even sometimes 10-fold variations in the costliness with which the different doctors would treat a patient, with no evidence that the more costly treatment produced a better outcome. And the trouble with the fee-for-service model is it systematically always rewards with more revenue those that choose the most costly method of treatment at a time when what we need is innovation in the adoption of less costly but effective treatments. As this scenario has played out, it's created a conflict between providers and payers. As the third-party payers have tried to find ways to limit the costs, so they say to doctors, something I would find enormously abrasive if I were a physician: you can't do this operation on your patient that you believe ought to be done without first calling 1-800 someplace in North Dakota and getting permission from somebody sitting in front of a computer. So doctors get infuriated by that and antagonized, and it's very costly. This system blocks rational resource allocation across the system of care. It doesn't provide any match between the resources used and the needs of the population served. Too many beds, too many cardiovascular surgeons, not enough primary care. As I'm sure you've been learning here at a School of Management, one of the first ideas of management is that for the good or service you're trying to produce, you try to match the resources used to the needs of the good or service that you're producing. And there is little or no accountability for cost or quality of care in this system. We believe that it would be possible to get substantially better care at less cost through what we call accountable health plans. That is, integrated financing and delivery systems that link the insurance component with the doctors and the hospitals, systems that take responsibility for individuals' comprehensive care for the year in which they're enrolled, for a fixed per capita payment set in advance, so that the providers of care are at risk for the cost of care and for the cost of poor quality. That is, if they do the operation poorly and there are lots of complications and prolonged hospital stay and so forth, they pay for it, not the patient. And a system in which providers could be held accountable for the quality of outcomes. Now then the question comes up, well, if you had such a framework, how would health plans cut cost without cutting the quality of care? It takes me back to 1978 when I gave the Shattuck Lecture to the Massachusetts Medical Society, which was called Cutting Cost Without Cutting the Quality of Care. I'm still playing the same record, but I've got a lot more ideas now of how you could make that happen. I think one of the essentials in an integrated financing and delivery system is to attract the loyalty, commitment, and responsible participation of physicians. That they believe this is their organization, they're a part of it, they're part of the management, they're responsible, and they want to make it work, so that you don't have games between payer and providers. They're on the same team, committed to their program. Then I think there are many things. I could go on for an hour or more just giving examples of ways in which care could be, the cost of care could be reduced substantially without cutting the cost. For example, as David Chin at Harvard Community Health Plan and as physicians in many other organizations are doing now, to start studying practice variations. I was recently working with physicians at Kaiser Permanente. One example, they're looking at hospitalizations for childhood asthma. In their view, if a child has to be hospitalized for asthma, that's kind of a demerit, a mark of a treatment failure in the outpatient setting. So they gather the data on hospitalization rates per child in all the different medical centers, and they find a wide variation. And so they go to the center that has the lowest hospitalization rate and investigate what they're doing and study it and find, yes, children who needed to be hospitalized were. It's not as if anyone was denied care, but that they had a much more effective treatment methodology so that outpatient care was much more successful. So then they ask those doctors to write up their treatment methods, and then they invite the other doctors in the other medical centers to come and visit with their partners and examine this better way, and then to try to spread best practice throughout the organization. Same for another example we were looking at was average length of stay for a transurethral resection of the prostate. In some medical centers it was 2 days, and others it was 5 days. Go and study what the 2-day people are doing, find their patients do just as well, no evidence that they were shortchanged in any way. Let's get the other doctors to adopt their methods. Other things, matching resources used to the needs of the population served, particularly with the physician mix. Around where I live, and I'm sure around here too, we have too many surgeons. And too many surgeons are bad for your health, and they're bad for your pocketbook, right? Bad for your health because either they're not proficient or they are proficient doing inappropriate surgery. Bad for your pocketbook because you have to support them at their appropriate lifestyles in greater numbers than you really need. So what does a quality, cost-effective organization do? Hire just the right number of surgeons so that they can be kept fully busy with a full operating schedule, make a good living at a low cost per case because they've got a lot of cases. And in that case, they can get their surgery for a much lower price and it gets done better because of the proficiency of the surgeons. And then plow the savings back into more primary care because they know that the customers judge the quality of the program primarily by their relationship with and their access to their primary care physician. Other things, concentrate costly specialized procedures in efficient regional centers. In California, we have 120 hospitals doing open heart surgery. Half of them are doing less than 200 cases a year. They're kind of at the high end of the death curve and the high end of the cost curve. We could have a lot lower mortality rate and a lot lower cost if all that open heart surgery were concentrated in relatively few, maybe 25 or 30 regional centers, each doing the surgery in high volumes with better results. Administrative economies of scale, ability to access and reallocate capital appropriately, quality management techniques, use of paramedicals. I saw in the New England Journal a few weeks ago that there was an article comparing nurse practitioners doing fiber optic flexible sigmoidoscopies with gastroenterologists. And as far as I could tell from the article, the net of it was you couldn't tell the performance apart. That is, that the nurse practitioners did just as well as the gastroenterologists, which is not surprising when you think of this as I presume, a relatively simple procedure, doesn't require great intellection to do this. I was discussing this the other day at a meeting with somebody from the University of Oregon Medical Center, and he said, yes, we have technicians now doing single vessel heart catheterizations, and we find their complication rate is about half that that's achieved by the physicians when they do it, because these people are especially trained for it. That's all they do. They're doing it all the time. So just large opportunities for of that sort. And generally speaking, I would say in healthcare, quality and economy go hand in hand. The correct diagnosis done promptly, the appropriate procedure done by somebody with great proficiency will be best for the payer and best for the patient. One more remark about these systems I might throw in, and that is to say, people express great concern about specific defects in our healthcare system that they see as just one particular thing that needs to be addressed on its own, that I see as symptoms of a flawed system architecture. Let's take, for example, lack of childhood immunizations. A little over a year ago, the President, very appropriately, expressed great concern about the lack of childhood immunizations, which is really scandalous in this country. And so somebody advised him, the thing to do is for you to have the government buy up the vaccine supply, which left me out there in California scratching my head and thinking, well, what would he do with it if he bought up the vaccine supply? And so I wanted to send a message back to Washington in the style of James Carville and say, it's the delivery system, stupid. That the problem is in the traditional system, there is nobody who can be held accountable and has the resources to get the immunization level up to an appropriate level. Now in California, where we have a lot of competing HMOs, for one thing, they have the incentive and the resources, and they have the children's names and birth dates in their computer, and they do get much higher, I guess they didn't agree that this was the delivery system, and they do get much higher immunization rates, up in the 88% or something like that. I think it ought to be somewhat higher, but we can at least work with that and contract for that. So when you see lack of primary care, lack of immunizations, it's often an inappropriate architecture. Now let me come to managed competition. We have in our market for healthcare some significant sources of market failure. A question frequently asked me is, if these integrated systems are such a good idea, why haven't they taken over the world, and why haven't they held down costs? And my first reply would be that employers, government, and health plans have worked together to create price inelastic demand. For you non-economists, by price inelastic demand, I mean if you raise your price, you raise your revenues. Whereas if you have price elastic demand, if you raise your price, you lose so many customers that you lose your revenues. What we as purchasers want to see is elastic demand, so that if a health plan raises its premiums a little bit, it loses a lot of customers, so it won't do that again. It'll focus on bringing the costs down. Well, why do we have price inelastic demand? And how could that be corrected? This is at the heart of managed competition. First is, it's still the case that many employers, perhaps most in this country, pay more on behalf of people who choose the traditional fee-for-service plan. And they say, oh yes, we offer HMOs and we pay for all of that too. But the effect is the employee who chooses the less costly plan does not get the savings, and therefore has no incentive to choose the economical plan, and therefore there's no incentive for a health plan to be the economical plan. Now, some employers are beginning to change. Next problem, a serious problem, is that health benefits, employer paid, are tax-free to the employee without limit. And here's the problem. Let's say last year at Stanford, families had a choice that included Kaiser Permanente, our most efficient HMO, and a Blue Shield plan. One was $420 a month and the other was $520 a month. The family choosing the $520 plan could write a letter to Stanford saying, pursuant to Section 125 of the Internal Revenue Code, please reduce my salary by $100 a month and pay that for me. So that person would be paying about $50 a month in net after-tax income. The problem so that their incentive to choose an economical plan was cut in half. A serious problem with that is, imagine hypothetically that I went to Kaiser and said, we would like you to cut your premium by $1 a month. And they'd say, gee, Alan, why should we do a dumb thing like that? That cost us $2.6 million a month right around here. And I'd say, well, if you would do that, you would be more attractive to my colleagues at Stanford and more of them would join you. And they'd say, come on, Alan, we know better than that. If we cut our price by $1 a month, you and your buddies at Stanford will only see about 50 cents a month. That is, their marketplace reward for cutting price has been cut in half by the workings of the tax law. Or to take this example one step further, the family who chooses Blue Shield in this example pays $50 a month less in taxes than the family who chose Kaiser. So it's a heavy tax on cost containment. There are other problems. Non-standard benefit. You've probably seen that if you've seen choice of health plan situations. You know, Plan A has wonderful vision care and no podiatry. Plan B has wonderful podiatry and no vision care. So what happens? In business school, we call it segmentation. All the people with bad feet and good eyes, they join Plan B. And all the people with good feet and bad eyes, they join Plan A. And now, if Plan A raised its price by $20 a month, what you'd like to have is a lot of people running away from Plan A and joining Plan B. But they don't, because a lot of them have bad feet and good eyes, and they want to stay at Plan A. And so the answer to that is what we've done in the California Public Employees system, or at Stanford, is we standardize the coverage. We say if we want vision care, you're all going to provide vision care to the same standard. Shopping and plan comparison is very costly because people don't have the information presented in a one time in one place in a convenient format. They don't have information on quality. You have Professor Mnookin now, who's at whose home I'm going to be staying tonight, was at Stanford at the time. At Stanford, we adopted managed competition, and Professor Mnookin stood up in the faculty senate and said, "Oh, Alan, aren't you trying to use economic incentives to steer us into El Cheapo?" And I was benefits committee chairman at the time, and I drew myself up and I said, "We don't have any El Cheapos around here. We have only high-quality healthcare plans. But if you are asking about our low-price plan, Kaiser Permanente, I have a report here which says for the last 5 years running, their hospital in San Francisco has had the lowest mortality rate in the state for open-heart surgery. Is that what you're looking for? Why, thank you." While the dean of our medical school cringed in the back and said, what does your report say about Stanford? And then we would have gotten into a big complicated discussion about risk adjustment, case mix, and so forth. Another problem that's very important, a cause of market failure, is that in small employment groups, people are often not given a choice of plan. A group of 5, 10, 15, 25 people is too small to offer 2 or 3 different competing health plans. And so you get into a kind of unanimous consent situation where unless everybody's willing to change, you don't change. And so it's very hard to get people to move from one plan to another, give up their doctor-patient relationships, and the like. Now, here, if I get into public policy briefly, is to say that unfortunately in the Clinton plan, they failed to limit tax-free employer contributions, which leaves in place a heavy tax on cost containment and reduces confidence that market forces will control costs. Another major problem that managed competition has to deal with is that risk selection is a very important issue that must be addressed and must be addressed seriously. Expected medical costs vary widely among people, young versus old, healthy versus chronically ill, and capitation and competition, as Professor Joe Newhouse of Harvard has pointed out frequently and eloquently, create incentives to select risks and to make health plans unattractive to people with high expected medical costs. The older I get, the less I like that idea. So managed competition includes a design that attempts to take out the ability and the incentive for health plans to compete on risk selection, instead to reward them for bringing down the cost and improving the quality of the service. And includes an annual enrollment process where through the enrollment process the health plans have to take all comers, guarantee continuity of coverage, but particularly have risk-adjusted premiums. That is, payments that go from those plans that get favorable selection to those plans that get unfavorable selection to compensate them for that. Next major idea in the Jackson Hole vision is that small employment groups need to be pooled into large purchasing cooperatives. Small employment groups, I'm thinking of under 100, say, and individuals, are too small to spread risks, to achieve economies of scale in administration, to develop expertise to acquire and use information, to manage competition, and they're too small, as I said moments ago, to offer choice of plan to the individual subscriber. So what we've proposed from Jackson Hole is that we ought to cover America with what we call health plan purchasing cooperatives. The acronym is HIPIC, and I've read a couple of times that the Clintons changed that name to Health Alliances. I'm glad they did, but that people find Health Alliances somehow sound like Big Brother. Sapphire wrote in the New York Times about this last summer and said, well, HIPIC sounds kind of friendly, like, hey honey, I'm going down to the HIPIC to buy some health insurance. Can I bring you anything home? Well, the idea is to have a pooled purchasing arrangement that would resemble a large employment group, in which everybody in the system would pay the same premium for the same coverage, so the risks would be spread widely, and administrative costs would be reduced. The idea came from the California Public Employees Retirement System, whose advisory council I have the honor of chairing, in which we care for over 920,000 people who are the employees, retirees, and dependents of over 900 public agencies in California. We offer a choice of 19 different competing HMOs and 2 PPOs. And the effect is even very small employment groups. My favorite example of a small employment group is the Mosquito Abatement District of Antelope Valley, which has 2 employees. And you think about how this works from the point of view of those mosquito abaters. Well, once a year, each of them gets the brochure, describes all the health plans in their area that they can choose. The premium they pay has nothing to do with their own health status because their health risks are spread back over tens of thousands of other people. One mosquito abater can choose Kaiser while the other one chooses Blue Shield or vice versa. So you have individual choice of plan. And the administrative cost in this scheme is about 1/2 of 1% of premium. It's very efficient because of economies of scale. Now, one of the things that's happening in the political process is that people who don't like this idea say, all right, we'll have pooled purchasing arrangements, but they have to be voluntary. And the bad news is, I fear, if you make this voluntary, then it won't work. Because guess who will be at the head of the queue to get in and get themselves pooled? All the sick. And who will say, I want to stay out of the pool because I can get a better deal on the outside? All the healthies. And the purchasing pool will fail in a spiral of adverse selection. So as much as I regret limiting anybody's freedom to do anything here in the land of the free, if we want to have stable, reliable health insurance, we have to have large-scale pooling, and large-scale pooling won't happen without incentives. It can't be completely voluntary. The Clintons picked up on this idea, which is as yet a relatively untried idea. I think we're doing great things in California with the HIPIC for public employees and the HIPIC for private sector employees. And they said, this is such a great idea, everybody is going to be into what they call the Health Alliance, which, in my view, means it's going to have to be a state agency, subject to political control, too ready a candidate to be a regulator and even a single payer, and very large implementation risks if they don't carry it off well and if the customer service is poor. And that's brought on a lot of opposition to this whole idea. Finally, the 5th idea of managed competition is that we do need oversight by what we call an independent national health board. Let me just give you one example of what I mean. A poor man over here has AIDS. The doctor over here says, oh, we can treat that with autologous bone marrow transplant therapy. This actually happened for $150,000. And the man says, I want that. And he goes to Blue Cross and says, Blue Cross, I want that. And the Blue Cross says, we have a contract with you which excludes unproven and experimental therapies, and this is one of those. And so we won't pay. And so the good old American way, it goes to court, and there's a lawsuit. And they bring in David Eddy, America's premier evaluator of medical technology. And David testifies eloquently, there's not a shred of evidence that this therapy would do this man any good. And the judge says, doesn't matter, you have to pay anyway because that's his only hope. So we believe that we need a national health board that could make science and value-based determinations, and in the definition of the covered benefit package, perhaps make a finding that says, in our finding, health plans cannot be sued for not providing autologous bone marrow transplant therapy for AIDS because we find no evidence of efficacy. Now, unfortunately, when the Clintons took over this idea, they had a very different idea of the National Health Board. First, that it would be a part of the executive branch of the government under his political control, and that the main thing that it would do is to establish and enforce a national health budget and budgets for every health alliance and price controls for every health plan. It would not be an independent agency, not insulated from political control. I believe that and the rest of the over-complex apparatus of the Clinton plan makes the whole healthcare industry a federal government program. 2 or 3 weeks ago, the Congressional Budget Office came out with its assessment of the Clinton plan. And they said, the Congressional Budget Office, is a nonpartisan agency that works for the Congress. Its leader is appointed by the Democratic leadership of the Congress. So this is not Attila the Hun talking now. It's a nice Bob Reischauer. And what we have is the CBO concludes the Clinton plan, establishes both a federal entitlement and a system of mandatory payments, regional alliances, corporate alliances, would operate primarily as agents of the federal government. CBO believes that the financial transactions of the health alliances should be included in the federal government's accounts, and the premium payments should be shown as government receipts, in other words, taxes. The administration proposal specifies outcomes, dictates the means, prescribes the financing mechanism that must be used, and enforces the prescribed transactions. The program does more than redefine the terms or conditions of pre-existing private transactions. The new program seems to represent an activity of the federal government that relies on the exercise of sovereign power. So this really is making the whole healthcare industry a federal government program. In my view, the Clinton financing plan puts the federal budget at enormous risk. It says that employer payments, if the employers are in the alliance, and every employer will get in the alliance because of this feature, employer payments are limited to 7.9% of payroll. What that means, in effect, is if healthcare costs continue to rise faster than wages, which they've been doing in this country for the last 50 years that we know about, and which they've been doing in Canada and in Britain, for example, then the federal government is at risk for the difference between the revenues that come in from the payroll tax and the revenues that need to be paid out to pay for the health care. And this could become an enormous cost to the federal budget and to the taxpayers. I did a rough calculation that suggested if from 1996 to 2000, if healthcare costs grew in real per capita terms at the same rate that they've been growing in Canada in recent years, the federal budget would be about $160 billion a year. The deficit would be $160 billion a year greater than is projected in the Clinton plan. So then in the legislation, they said, well, we'll put in a cap. We'll put in a limit on how much the federal government can subsidize health care. You know, so in 1999, the federal government, the law says, will spend no more than $80 billion, or whatever the number is. I was at a conference with Henry Aaron of the Brookings Institution, at which I said, to me, that reads like the national debt limit. You know, it's not something you can take seriously. And Henry Aaron corrected me and said, no, Alan, a better analogy would be the Medicare Hospital Trust Fund. Every time they get close to seeing the money run out, they raise the taxes. So I just don't think that capping federal subsidies, as in the Clinton plan, can be taken seriously. What about the price controls? I complained earlier about the weak market forces in their plan. Well, real per capita spending in this country from 1985 to 1990 grew 4.6% a year. In Canada, it grew 3.5% a year. In Great Britain, 2.5% a year. The Clintons' goal is 1.5% in 1996, 1% in 97, 0.5% in 98, and 0 in 99. In other words, the British National Health Service, who've been at it for 50 years now, could not meet the cost containment goals of the Clinton plan, not to mention Canada, the great mecca of the single payers. And if those goals are not met, then the price controls are applied. And I think that means the price controls are not a fallback, as the president says. They are, in fact, the first line of attack. But federal price controls won't work for a number of reasons. One is the incentives are wrong. The incentives are to take advantage of every allowed increase and then fight for more. Politically, regulators can't force insurers into insolvency, forcing millions of people to change health plans, throwing thousands of people out of work. It's an example of what Charlie Schultz in his Godkin lectures here back in the 70s said, the rule of do no direct harm. The government cannot be seen as directly harming people. Perhaps more fundamentally is the Fifth Amendment. That is, that the government cannot take private property without due process and just compensation. And the way that the Supreme Court has interpreted that in the case of regulated industries has been that the regulated industry has to be assured a fair rate of return. But the trouble is, if you are assured a fair rate of return, whenever your costs go up, your revenues have to be allowed to go up. It's a form of cost reimbursement, which is why I think most economists are pretty skeptical that public utility regulation lowers costs to consumers. So The Clinton proposal in Section 5232 proposes to suspend the Fifth Amendment for health plan price controls. That is to say that the determinations about the National Health Board with respect to health plan prices are not subject to administrative or judicial review. I don't know whether that'll get past the Supreme Court or not. I discussed it with my law school colleagues, but I think if it were to get past the Supreme Court, it would be a pretty frightening prospect for anybody in the healthcare industry. It would say, in effect, if you're in healthcare, you've lost your Fifth Amendment rights with respect to the taking of property. So I summarize by saying that I think Clinton's plan would create a single payer in Jackson Hole clothing. Virtually all of the costs would be paid by the payroll tax or other federal revenues. The money would flow through the state health alliances, which the CBO described as agents of the federal government, and there would be federal price controls on premiums. Then you might say, well, what's so bad about a single payer? Again, it would take too long to explain the whole story. In questions, I might be happy to come back to that. But I'll just tell you, I spent the 1960s in the Kennedy and Johnson administrations as point man for Robert McNamara on trying to bring cost effectiveness to the Pentagon. As Julie pointed out in the introduction, I received a medal from President Kennedy for trying to do that. If you can imagine such a quixotic task for a young man. And what I learned is that there is no political constituency for cost effectiveness in government. The ideal weapon system is built in 435 congressional districts, and it doesn't matter how much it costs or whether it works or not. Government, in fact, is inherently an ineffective, incompetent, inefficient purchaser of whatever it buys. And you find it, each new Secretary of Defense, like Stanford professor and friend of mine, Bill Perry, becomes Secretary of Defense, and he says, I'm going to straighten out and reform those costly, overly complicated, et cetera, wasteful procurement laws. And I could just hear those words ringing from 30 years back when my boss, Bob McNamara, said the same thing. And a single payer would be an enormous concentration of unchecked power in the hands of a few people. Finally, to close on a cheerful note, Clinton's plan can be fixed. Now in New York, I got a lot of publicity because I sort of got a little bit too wound up here. And I said, well, I would suggest you start by deleting pages 1 through 1342 and replace it with the Cooper Bill. And in fact, I still believe that. But here would be some fixes that would make the Clinton plan a whole lot less worse. First of all, assure access. Don't create a new entitlement. I mean, entitlements are now killing us fiscally. We don't know how to control the costs of the entitlements we've got. So to create this enormous new one, I think is just fiscal insanity. I feel like I'm composing in my head an article which would call the Clinton Health Plan a long day's journey into the night for the taxpayer and the American economy. We should limit tax-free employer contributions to the price of the low-priced plan. We should maximize everyone's incentives to make the market work and forget about price controls. Maintain a pluralistic purchaser environment. Instead of one government monopsony purchaser in the Health Alliance, we should keep the larger employers in the game because they have been the main source of innovation in the development of more innovative and more effective purchasing arrangements. Medicare is still frozen in a 1965 model of the fee-for-service solo practice remote third-party payment model that I criticized earlier on. We ought to keep employers involved in cost containment. We shouldn't guarantee them that they'd only spend 7.9%. And we ought to eliminate the major windfalls to employers, such as the Clinton plan says early retirees' costs will be taken over by the government. That's worth about $10 billion to General Motors. All you nice people are going to pay more taxes to relieve General Motors' balance sheet of $10 billion and several billion dollars from Ford, Chrysler, and others. When some of these companies say, oh, they're in favor of the Clinton plan, well, I guess every company has its price. It is not too amazing that for $10 billion, General Motors would say, yeah, we think that's a good idea. We don't care what else is going on with your plan. And other windfall benefits, prescription drug beneficiaries for Medicare beneficiaries. And let me conclude by saying, I believe Medicare beneficiaries ought to have a prescription drug benefit But I also believe that they ought to get theirs exactly the same way that I got mine, which is at no cost to the government, joining a cost-effective HMO, which could pay for that prescription drug benefit out of the savings from their more efficient operation. And that would be the way to use prescription drug benefits in Medicare, is as an incentive for people to join HMOs that could save Medicare money. Thank you.
Thank you. We've invited two individuals holding very different positions to comment briefly on Dr. Enthoven's remarks. The first of these is Deborah Stone. Deborah is the David R. Pockross Professor of Law and Social Policy at Brandeis University. She's a political scientist by training, having received a PhD from MIT, and she's been on the faculty of Duke University, Tulane, Yale, and MIT, as well as Brandeis. Deborah's research covers a wide range of topics, but most important for tonight's discussion is the work that she's done on financing and providing health care in this country and comparing that with the way health care is financed and provided in other countries. This year, Deborah is a fellow in ethics at the in the Ethics and the Professions program here at Harvard, housed at the Kennedy School, and she's working on a book on the struggle between market and commutarian concepts of insurance. Deborah.
Thank you. Well, much as I think Alan Enthoven would like to disown the Clinton plan, I think I'm going to have to pin him with being the intellectual progenitor of it. And I actually mean that as a compliment. He is really the father of the managed competition idea. And I just want to quickly sketch, he did a nice sketch of the plan, and I want to single out what I think are the really creative ideas behind that were innovations in health policy thinking. First of all, he had the idea in thinking about medical care as a market to shift from thinking of medical care as the good that people buy to thinking of insurance or financing as the consumption good, the thing that people will choose among. And then he kind of animated this plan by having consumers choose plans rather than medical services as they behave as economic actors in the market. Another feature of his idea, of the whole managed competition idea, is that it's competition among these plans, what he calls integrated finance and delivery plans, that generates efficiencies and therefore produces cost control or cost containment in the system. All of that stimulated by, of course, cost-conscious buying, cost-conscious choices among consumers. Lastly, he understands and has always understood that there's an imbalance of power between consumers in either a medical care market or an insurance plan market and the providers of medical care and insurance plans. And so he would always have an umpire. Originally he called it a sponsor, later it became HIPICs, Health Alliances and HIPICs and so on. But he's built into this idea of market competition an umpire. I think it's a brilliant and intellectually audacious conception, but I think it's wrong. I think it's wrong in three big ways. I think it misunderstands the nature of insurance. I think it's wrong about medical care, about how we conceive of medical care and what we want it to be. And I think it's wrong about accountability and what sorts of mechanisms will really provide the kind of accountability that people want and that people seek in a political system as opposed to a market system. Let me see if I can do this in 5 minutes. Insurance, 101. Insurance is a mechanism for pooling risks, for letting the many subsidize the losses of the few. It works best by aggregating people in large groups. The bigger the losses that we want to cover through insurance, through some kind of mutual aid system, the bigger the group we need. When insurance is set up by profit-seeking firms, instead of by social groups themselves. And both health and life insurance were originally set up in this country by grassroots mutual aid societies or benevolent associations, fraternal orders, and so on. When profit-seeking firms set up insurance, they have every incentive to select healthy people because the customers of insurance are the company's raw materials, and they can make a better profit if they start out with good raw materials. Managed competition, I think, maintains all the incentives of having multiple for-profit insurers compete with each other. It maintains all the perverse incentives, and I do mean perverse. It's extraordinary to me how a country can arrive at a health insurance system that only insures healthy people. That's really the situation we're in the United States. In Europe, they call it sickness insurance, by the way. The French word and the German word for health, what we call health insurance, is sickness insurance. And they look at Americans and they say, what do you need insurance for if you're healthy? Well, in the United States, that's a problem. Managed competition maintains these perverse incentives, I think, in several ways. First of all, by preserving multiple insurers competing with each other in a market to be profitable, that intensifies the incentives to cream skim. That, no matter what legislative prohibitions or rules we set on insurers not to select healthy people, not to be able to use pre-existing condition clauses and so forth, they are still going to use various strategies to try to do that. And they have several available to them. Obviously, they can do selective marketing. They can locate their facilities in places where richer and healthier people tend to live. And there will be a certain amount of self-selection into health plans by income, because if we limit the amount of subsidies, either through tax expenditure, limiting the tax deduction, or any government subsidy to people with low incomes, for those people, the lowest cost plan will be the only realistic choice they face. So you will get a certain de facto segmentation of people into plans by income, and there's such a strong correlation between income and various measures of health status and also risk status, the potential to develop disease, that you'll get a certain amount of de facto segmentation by health status. All of that means that this system of multiple competitive plans requires some kind of apparatus to correct for the segmentation that's going to result. And it's an apparatus that Professor Enthoven has sketched out. You need a fancy risk adjustment system. You need a monitoring system in the first place, but you also need a risk adjustment system, which means you need somebody, and it's going to be the health alliances, collecting the very same demographic and health status information on all those individuals that commercial insurers were once collecting in their medical underwriting. Now that information has to be collected by the health alliances so they can do the risk adjustment. That raises terrific privacy concerns and terrific worries about stigmatization, I think, which we could talk about later. Let me talk about the conception of medical care. As I said, in managed competition, the patient becomes a consumer and shops for insurance plans as opposed to shopping for medical care. The whole managed competition idea transforms medical care in a couple of, I think, not so good ways. What is called integrated financing and delivery systems, I might call a lumpy good. Now you can't shop for your doctor and your financing separately. Those are not separate choices. You have to make them all at once. By choosing a financing system, you are choosing the set of doctors and hospitals that financing plan allows you to use. And by the way, those of you who've signed up for various managed care plans around the Boston area know that the choices are far more limited than meets the eye in the advertising brochures. I can go into that later too. It's a little bit like once we used to be able to buy cars and we could choose all the features of the model of the car that we wanted, and we could also, in choosing a car, decide on our own schedule of where we wanted to go and what we wanted to use this for. And now suddenly we're getting a system where when you buy a car, it comes with a fixed transportation schedule, like the MBTA. So you have to choose both the features of your car and the features of your transportation system at the same time. When you choose a managed care plan, you are choosing a style of practice, a philosophy of practice, all that stuff that's built into the 1-800 number. And there are still going to be 1-800 numbers. Yes, they came in before managed competition, but there are going to be 1-800 numbers. There's going to be a ton of so-called utilization review and micromanagement of physician decision-making, because that's how managed care plans are going to create efficiency. I also think that by making the patient into a customer, a managed competition plan really changes the nature of the physician-patient relationship. It's no longer a relationship with a lot of dimensions, but the key dimension is just one choice, what Albert Hirschman calls exit. You buy or you don't buy. You take it or you leave it. You like the features of the plan or the doctor or you don't. Managed competition has a lot of features to protect a patient's ability to switch once a year, usually, but not a lot of mechanisms to preserve dialogue, to preserve the relationship that we care about when we go to the doctor. Plans, theoretically, will worry about whether their primary care physicians please their patients and create good relations, but I really wonder whether plans in a competitive environment will emphasize physician-patient relations, reassurance, talking, explanation, bedside manner, all those unmeasurable things. Will they emphasize those over the bottom line, what expenditures physicians generate? Let me talk last about accountability, the conception of accountability built into managed competition. In the managed competition plan, the quest for efficiency is the driving force. It's the motive for these integrated finance and delivery systems. It's what they pursue to make them run. And it's also the mechanism for cost containment, for keeping rates of growth and also absolute cost down. I want to caution us against thinking of efficiency as some kind of objective standard or universal norm that we want our health plans and our doctors to be pursuing. I think efficiency is something that can only be judged from a viewpoint, from a stance. Efficiency is a relationship between input and output. And in a standard economics text, efficiency is being able to produce more output for a given input, or the most output for a given input, given a set of choices of how to produce things. Those inputs and outputs look different from different points of view. Just take the example of the doctor's waiting room. The doctor is a very expensive resource, and the doctor doesn't know how much time it's going to take with each patient. He doesn't know what each patient's going to have when they walk in the door. So the doctor schedules patients so there are always more patients in the waiting room ready to be seen, and not a minute of the doctor's time is wasted. A lot of minutes of the patient's time is wasted. Now that is efficient from the doctor's point of view. It's obviously not from the patient's point of view. Alan talked about his drug benefit being cost-free. Prescription drug benefit is cost-free to the government. It comes to him courtesy of a very efficient plan. I get a drug benefit in my managed care plan, and my drug benefit limits me to getting 30 days worth of a prescription at once. So if I take a drug, which I do permanently, I can't buy 6 months at a time. I have to make 6 separate trips to the plan. And if I'm going out of the country for 6 weeks and I need more than 30 days, I have to write for special permission to my plan. Those are costs to me that are hidden in the efficiency calculation of the plan. We could go on and on about the kinds of hidden costs. One big one that is hidden in a lot of the cost containment measures of managed care plans is the shifting of care onto unpaid family members, relatives, and other networks who take care of people as people are shifted out of the hospital. The point I want to make accountability is that with this ability to shift costs and costs only visible, with plans only looking at the costs visible to them, I want to know, are the plans accountable to you and me, the members of the plan, or are they accountable to their stockholders as they think about saving costs? These, I think, are some of the thorniest problems of managed competition, and why I think such a neat intellectual conception that works so well in theory hasn't really flown yet in the political environment. Thank you.
We're going to hear from one more commentator, and then we'll let Alan respond to both of them. Our second commentator is Charles Baker, Secretary of Health and Human Services for the Commonwealth of Massachusetts. In this capacity, he oversees 10 secretariats, and from discussions that I've had with some of his commissioners and deputy commissioners, I can report that they give rave reviews to his knowledge of the issues in the human services areas and to his willingness to support them as they take on the day-to-day battles of state government. From his political opponents, and lots of them are here, Charlie. They're disguised as Kennedy School students for the for the few years that the Weld administration is in power. I hear that when you go to argue with I hear that when you go to argue with Charlie, you have to use your numbers, hard facts, and real data, but that you're open-minded and listen to their arguments. It won't surprise you to discover that since Charlie is responsible for such programs as public assistance, Medicaid, mental health, public health, and child protective services, he's responsible for about 40% of the Commonwealth's budget. Clearly, one of his major concerns is the provision and cost of health care, and health care reform is high on his and the governor's agenda. Shirley.
5 minutes, okay. I'm going to give a relatively brief commentary here and not give the usual bureaucratese, because I know there's a lot of people out there who probably want to start asking some questions. The first is that I'm going to use an example to sort of describe what I think good health care looks like. And I have two sons, one of whom's 3 and the other of whom is 2 months old. We're members of Harvard Community Health Plan. And my 3-year-old, about a year ago, suffered what was pretty obviously an asthma attack. I happen to think that one trip to the hospital for pediatric asthma is fine. I think it's more than one where you start to have a problem because you have to discover it in the first place. What I will say about this was the relationship between Children's Hospital and Harvard Community Health Plan on this was staggeringly favorable. They are obviously in a relationship. And they are, in fact, in a relationship. HCHP signed a big contract with Children's that made a huge difference to Children's, and Children's is obviously busting their butt to make it work, and vice versa. Charlie was admitted. He was taken care of through the night beautifully. The next day, there was a big conference with the people from HCHP. Everybody decided he needed to stay one more day. We went home with our nebulizer, our Ventolin, and our saline, and our phone numbers. And one of the things I will say is there's no question that one of the ways you save money in healthcare is by shifting costs, time and activity, whatever you want to call it, onto family members. And Charlie has not been back in the hospital, and that's because we have a nebulizer, we have a number we can call, we have people we can talk to, and we do a damn good job of keeping him out of the hospital, which we consider to be our goal and objective as well as theirs. I think that's fine. And if you go to Japan, you'll discover that they have very long lengths of stay in their hospitals. But guess who brings the linen and the food to take care of the person while they're in there? They're family members. I don't necessarily think that I don't think the healthcare system ought to be responsible for everything. I think individuals and families have certain responsibilities that they have to live up to as well. I think culturally the biggest problem we have with healthcare is not that fee-for-service has failed. It's that American culture believes that more is quality in healthcare, and frankly the medical profession has a lot to do with why they feel that way. You can add to that third-party reimbursement, open-ended tax law, employer-based coverage. Employees pay for health care. It comes out of their wages. Or it comes out of the prices they pay for other goods that they buy from other people. Employers do not pay for health care. It's a pass-through. Medical education, the whole notion of advocacy on the part of physicians, that created a lot of the demand as well. And Medicare and Medicaid, growing up as historical cost-plus fee-for-service programs, ratcheted health inflation in the 60s and 70s clean out of sight. Let me just say two other quick things. Washington will be serious about health care, and I believe they need to be serious. Medicare is 40% of hospital revenue in Massachusetts. ERISA, which is federal pension law, oversees 70% of privately purchased employer-based health care. HMOs are federally chartered. Tax law, as we mentioned before, at the federal level is completely open-ended for employer-purchased health care, and is probably among the most regressive tax law we have in this country. The more you make, the more your health benefits are, the bigger your tax subsidy is. That is clearly not the American way. And graduate medical education is financed and driven primarily by federal financing policy. I, as a state official, would love to think that there are ways for states to solve the health care problem on their own, but any plan that I put together looks like a Rube Goldberg, and it has to look like a Rube Goldberg because the feds control a huge portion of what drives the incentives and the decision-making, the financing, and the regulatory apparatus that the healthcare system is built on. But if Washington is serious about this issue, a number of things will happen. There will not only not be tax caps, there will be no tax subsidy for the middle and upper class to purchase health insurance. There will be lots of tax subsidies for poor people. Everyone in this room should not be buying taxpayer-financed, subsidized health care, period. Because fundamentally, if you want to see real incentives on the part of everybody who's in the system to hunt for value, to hunt for quality, to hunt for cost control, you take away that tax subsidy and you give it to the people who deserve it. Second thing that will happen is Medicare and Medicaid will be prospectively financed and risk-based between the providers, the federal government, and the state. As long as Medicare is basically a reimbursement-based program, and as long as Medicaid is a reimbursement-based program, those two programs will continue to grow at astronomical rates because all the incentives are designed to just make the machine churn it out. Third thing that will happen is you'll get real insurance reform. And that will mean that of the 1,500 insurance carriers in the United States, 1,200 of them will be gone in less than 12 months. And you'll have 300 carriers left who are willing to play by the rules associated with being in that business. And that will do more to reduce administrative overhead and a lot of the baloney associated with claims processing, billing, utilization review, and all the rest than practically anything you could do on a top-down basis. We will either end tobacco subsidies or we will raise the tax on cigarettes by somewhere between $1 and $2 a pack, and the money associated with doing that will go into community health programs and public education around the dangers of tobacco. And finally, we'll cut the cord on employer-based coverage. That is probably the most radical suggestion that I'm making, but there's simply no question that who you work for in many respects dominates the nature of the health care coverage you have in this country. And until we're willing to acknowledge that fact and to say that if we're going to have the government subsidize this, it should subsidize families and households. And if an employer wants to administer and manage and support purchasing for this, if unions want to do it, if churches want to do it, if social clubs want to do it, fine. But don't make somebody who changes their job have to change their health care coverage. There are so many uneconomic decisions that get made out there by individuals all the time based on this fundamental problem that it's simply got to be part of what we do to solve the problem. Now, I just want to say one quick thing about Professor Stone's comments, and forgive me, I can't help myself. In 1980, the two institutions I think most people would say were in the most trouble in this country were the auto industry and the public schools. The auto industry is a profit-making operation. The public schools are not. In 1994, the best cars that are made in the world are made by U.S. automobile manufacturers. And that's because they had to finance, or they had to change the way they behaved, not to satisfy their shareholders, but to satisfy their customers. And public education has at least as many problems today as it had 15 years ago. I would say more, and there's no end in sight on that one. Second thing I would say is it bothers me a little to say that in this country we don't cover people who are sick. The over 65 population is the highest utilizer of healthcare services by a mile, probably by a factor of 3, depending upon whose numbers you believe. And Medicare covers all of them. And what Medicare doesn't cover, in many respects, is picked up by Medicaid. I happen to agree with the professor here. One way you could really solve that problem in a short time frame would be to move aggressively. In California, Medicare recipients in Massachusetts use 2,400 inpatient days per 1,000 beneficiaries. Medicare recipients in California use 800 inpatient days per 1,000. There are gigantic opportunities there to pay for drug benefits and other things by doing a better job of managing. And if ever there was a population, in my opinion, that needs good managed care, it's the elderly. And the final thing I would say on that is there are about 650,000 plus or minus people in Massachusetts on Medicaid. About 150,000 of them represent the SSI population. They are easily the most disabled and the most chronically ill people in the Commonwealth. And our program picks up all of them. I think there are big problems with the American healthcare system. And I told my friends in Washington when the Republicans were theoretically in charge that this was a great issue for them and they should have been all over it. And I have been very tempered with my remarks with regard to the Clintons on this issue and on their plan, because as far as I'm concerned, we had 12 years to take this one on and we didn't. We blew it. And therefore, to some extent, I think we have to be very careful about what we say when the president and his wife had the guts and the courage to put this issue on the American agenda, and in many respects to bet the presidency on it. They deserve enormous credit for doing that. And I think the fact, again, that so much of this is driven by federal policy, even if you want to have a state-based system, you need the feds to get serious about enabling states, if that's what they want to do, to create opportunities and systems that work. And that simply is not feasible given the way the current system is structured, financed, and regulated. Thanks.
Thank you. Before we open up the floor to questions, I've promised Alan that he can respond to both the commentators. So Alan, if we can get you to respond quickly, and if people want to start lining up at the mics.
Julie, I'll do it quickly. I want to thank Professor Stone for crediting me with such an intellectually brilliant achievement, but I would like to underline that there is a lot of a practical reality behind this. You know, they say that an economist, and I'm an economist, they say an economist is somebody who seeks to prove that something that works in practice can also work in theory. And that's sort of what I've been doing, but in California now, like at Stanford, for example, we're wall-to-wall HMOs, and in CalPERS that I told you about, we're over 80% HMOs. That is people, voluntary choices, looking around, what do they like best, in their own best interest, that's what they chose. So it's not purely an abstract theory, and even here in Boston, 10 years ago, I was categorically assured that this idea could never work on the East Coast, but I understand more than half the people in the metropolitan area are in HMOs now. With respect to these profit-seeking entities, I'll have to confess that I started out as a kind of non-profit HMO aficionado. My idea of the good guys were Group Health Cooperative, Puget Sound, where I grew up, Kaiser Permanente, with whom I work, and Harvard Community Health Plan. But something I learned over the years, two things. One is that to expand and to get this job done in real time, you need capital. And so a lot of nonprofit HMOs converted to for-profit so they could go to the capital markets and finance expansion. And I couldn't see how others could do it just from retained earning without getting to the capital markets. And the other is I realized if I was going to be such a purist, as Professor Stone is, that I would find myself relegated to a little small minority, and that the only way you can become a national force is by willing to broaden your base a little bit. And so I came to the conclusion that nonprofit, for-profit is not the dividing line between good and evil. I'd much rather get my medical care from Hewlett-Packard than from a lot of nonprofit institutions I can think of. Now, next, when Dr. Stone says, well, the system only insures healthy people, if you let it, that would be true. But in fact, if you create the rules in such a way that there's an open enrollment process and they have to take whoever comes, I'll tell you, at Stanford and in the California Public Employees, where I have direct hands-on experience, those carriers take care of a lot of very unhealthy people. They provide them with open heart surgery and chemotherapy and all kinds of other exotic treatments. So it's possible to set the rules so that's not a problem. With respect to 1-800 numbers and micromanagement of physicians, that occurs in kind of the early to intermediate phases of the development of this whole thing. When you get to a mature system, what happens is the doctors understand that they are the key decision makers, and the smart thing for them to do, as let's say Kaiser Permanente doctors and Harvard Community Health Plan doctors have done, is for them to take charge, step up to the responsibility and say, we will accept responsibility to manage the cost and the quality. We'll make a deal with employers that we'll do the whole job for $150 a month per person or whatever it is, and then you get off our backs. We do the medical care. You can hold us accountable for consumer satisfaction and quality and measure it and so forth, but don't tell us how to practice medical care. No 1-800 numbers. So I think that the 1-800 numbers micromanagement is, it's not a part of competing HMOs. It's kind of an unfortunate passage that has to be gone through along the way. That's not how managed care really works. The way managed care really works is the way it is at Stanford or in the mature development in California. Our doctors are all on capitation arrangements. They get, you know, $160 per month for taking care of me, whatever my problem is. With respect to accountability, and do we want efficiency and so forth, I think that what we want is health plans that make their patients happy and that satisfy their patients and improve their quality of life. I do appreciate that there are some hassles, like Professor Stone. I also have recently become ensnared in the necessity for having lifelong chronic drugs. My wife figured it out faster than I did, and that is our HMO, seeking to make themselves more attractive to their competitors and friendlier to me, has told us if I fill in the following forms, we'll get the required drugs in the mail every 30 days, and so we won't have to go and fight for them, is thing one. Thing two is for the particular problem that you had, you don't have to write a letter and have a whole lot of hassle. When I have that problem, I just call my doctor's nurse and explain the problem to her, and she writes some kind of piece of paper, and they give me all the drugs I need. And the reason they do that is, of course, they wouldn't want to have Professor Enthoven complain about them. And finally,
a different attitude about drugs anyway.
yeah. And finally, I just have to pick you up on this point about because of all these reasons, that's why managed competition hasn't flown yet in the political environment. Well, now we've got the moderate Republicans led by Senator Chafee with their version of managed competition, using a lot of Jackson Hole concepts and so forth. And if Senator Chafee would be one of the first people to acknowledge us as his gurus, you have Jim Cooper and the Conservative Democratic Forum, the Cooper-Grandy bill, which is the only bipartisan bill, and the Brough-Durenberger bill in the Senate, and then we have, of course, the Clinton plan. So we have a whole lot of people out there. I would say it's flown like mad in the political environment, and I think the reason for that is because of that the idea of pluralism and choice is fundamentally compatible with American culture. You remember your de Tocqueville and how the Americans like to try things in a whole lot of different, multiple competing alternative ways, and that's what this is all about. Thank you.
We'll open the forum to questions. You know the rules. You should state who you are and affiliation and ask the question quickly. We're running late, but we'll try to ask a few.
Sure. My name is Patrick Myers, and I'm at the Harvard School of Public Health. I share Professor Enthoven's optimism about a mature system of managed competition, and my impression is that Mass General and Brigham Women's are sort of evolving towards that. My question, however, is one of the main reservations expressed about managed competition is that competition may be unsustainable in rural areas, like for instance Wyoming, which doesn't actually have any HMOs yet. So could you comment on how you think this potential problem should be addressed?
Well, I think that one of the really important things about rural areas is that we need organized systems of care. And that's the only way. We may have problems getting 3 different competing health plans in Wyoming, and maybe we can find some other ways of dealing with it. The purchasing cooperative might negotiate originally, you might have 3 different plans competing for the job, and one of them getting the contract subject to benchmarks and so forth. But I think the idea of the organized, integrated system is especially important. It's very hard to get good physicians now to go into rural areas, usually because of a sense of financial insecurity and professional isolation. The Mayo Clinic, for example, a couple of years ago decided that everyone living within a 120-mile radius of the Mayo Clinic would have convenient access to a Mayo primary care physician. And then they go and recruit doctors, and they can get good doctors to do that because they say, you're not leaving American medicine, you're not going to be isolated, you're going to be a Mayo Clinic doctor, you're going to be one of us, you're a partner in our group, but we need to have you work out in this small community. And beyond that, I think with organized systems, there are real possibilities, including ones that the Mayo Clinic is using, for telemedicine. When you get to the point that the population is just too thin and you can't afford to support a doctor out there, you can have a nurse practitioner aided by electronic communications, video, and so forth. You can have the Mayo primary care physician call into the specialists back in the mother church and video link the situation, have them look at the patient, examine and advise and so forth. There are a lot of possibilities that are beginning to come into practice now for making much better care accessible in rural areas. We may have to find some better metaphor than the kind of competitive system that can work in a metropolitan area like Boston or where I live. But I do feel that the organized integrated system, you need the capitation financing in order to provide a flow of money to pay for the video links and the paramedicals and so forth. You can't support the nurse practitioner out there on fee-for-service.
Yes.
Yeah, my question involves the employer mandate and universal coverage. One of the, well, I'm a little confused, I guess. It seemed when you started talking about managed competition and defining it, the number one thing was universal coverage with everybody paying into the system, and I think a subsidy was mentioned as part of that. By the time you got to the end, and with the criticisms of the Clinton plan, you wound up supporting the Cooper bill, or came very close to supporting the Cooper bill. One of the criticisms that I think you do have to address is that many of us feel that the Cooper bill, in fact, does not provide universal coverage, does not guarantee universal coverage. Part of the reason it doesn't is it doesn't embody an employer mandate that you can't have universal coverage unless everybody's paying the system. And I'm sorry I'm going a little long here, but many of the features of the Clinton plan that you object to, the cost controls and so forth, came as a result of subsidies to subsidize low-wage workers and small businesses. And many of us don't see in the alternative proposals any mechanisms to do that, and they don't really achieve a standard benefit package for all citizens, which you began as the fundamental feature of managed competition.
Well, your question is very well taken, and you shouldn't feel badly about feeling confused. There are times when I feel a little confused about it too, because it's very complex, and you know, working your way through this is a very complex matter. I think there are real problems with the employer mandate. The more I talk to employers of low-wage people, I become more aware of it. First thing is, as I'm sure you know better than I, that in a competitive business, the employer will pay no more in total compensation than the value of the employee's marginal product. That is what the employee contributes to the market value of the firm's output. And therefore, if you have an employer mandate, most, if not all, of the cost is going to come out of the employee's pay. Employer-paid health insurance is a myth. So the employer mandate can fall quite heavily on the backs of low-paid people, and people who are approaching the minimum wage. It may just mean they become disemployed. With the Cooper bill, which I think is a better point of departure, although I think it has real problems in it, the Cooper bill relies on subsidies for low-income people. It says everybody up to the poverty line will have their way bought into a health plan. And then from 100 to 200% of the poverty line, on a sliding scale, the subsidy will decline. That too has its problems. One of the big ones, as Henry Aaron recently pointed out, is that the implied marginal tax rate, when you phase out the earned income tax credit, all these benefits, you know, which have been looked at separately instead of on an integrated basis, then it becomes too uneconomic to work. And that's a problem that's going to have to be worked out. One of the great ironies I found in this whole thing is that the earned income tax credit, which I thought was supposed to be an incentive for people to work, then turns out to be a disincentive for people to work. The main way out of this is with money. That is, in the Chafee bill, for example, they phase out the subsidy out to 2.4 times the poverty line, and that produces a much more tolerable marginal tax rate. I think now, although I grant you the complexities and the difficulties, you know, are great, I think now that probably we have to find a way of progressively enhancing the subsidies for low-income people until we've gotten to the point that everybody who reasonably can be expected or can't be expected to pay for their own gets a subsidy. And then at the end of the road, after 5 years or so, cap it off with some kind of mandate, which might be an individual mandate, that is a free rider tax on people who don't buy health insurance. But I spent this weekend in Jackson with people who run large restaurant chains. This morning I was with Dave Sherb from Pepsi-Cola, who now employs 400,000 people. If they had a mandate, they might well lay off 100,000 of them.
I have to respond to that because I
Yeah.
work in a restaurant. I'm sorry, but I do have to respond to that. Under the Clinton plan, and I understand the subsidy is in question, and there's a lot of doubts and a lot of concerns, an 8% mandate for a restaurant winds up well under 3% of total sales, which is 15 cents on a $5 hamburger. Now, I've seen cost increases in restaurants over the past 15 years that I've worked as a bartender consistently, and I've seen restaurants adapt to them. And I have to say, I mean, I think there's been a lot of very effective lobbying on one side of this and not much analysis on the other side. I don't buy the argument.
Well, I think it's hard to avoid the argument that the mandate will fall on the employee's pay.
We have time for 2 more questions. Mark?
Mark Roberts from the Kennedy School and the School of Public Health. And this is for both Alan and for Charlie Baker. If you're going to say, as both of you did, that you have to have substantial subsidies to allow poor people to afford health insurance, and if you want to minimize administrative costs, it seems to me you confront the problem in any major subsidy scheme of the need for income determination for a fairly large share of the population. And Charlie, you know perfectly well from all the income-based programs that you run, this seems to me to carry with it enormous administrative costs because income is not a permanent feature of individuals, it varies over time. If that's the case, and if the employer mandate is ultimately paid by employees anyway, why not just go to a tax-supported system based on a payroll tax or even general revenue and give everyone a base voucher, a universal voucher scheme, so that you would do away entirely with the need to make income determinations, and by financing it through a progressive tax, do away with all these administrative costs. And then if some companies wanted to enhance the package for their employees or buy more expensive coverage for them, they could. And you could also, if you did this, I think fairly easily assimilate Medicare and Medicaid to such a system. And what I don't understand is if you believe that employer-paid health insurance is a myth, and why not just say that and let's do it with the tax system, which is the thing we devised to efficiently collect a large amount of money from people at minimum administrative cost.
Is that single payer? Certainly single revenue collector.
It's single revenue. What I'm actually trying to do is make a suggestion about how we could combine some of the competitive marketing features of a Jackson Hole plan with a more efficient revenue source from a tax-based system.
Okay, I think there's
sort of a hybrid.
3 answers to that. Living in a nation, as we do, that was founded on a tax revolt, including the Boston Tea Party over here, et cetera, et cetera. I think it's part of our political culture to be against higher taxes, and that's just kind of a fact. I mean, I have the feeling it's taken for granted in the Congress and in the administration that the American people are just going to be very intensely opposed to higher taxes. That would be point one. Point two, I would be concerned about...
Alan, does that mean you think it's a bad idea, or you think that
That's
it
my
won't
first
fly?
point. Okay, that's
Okay.
my first point out of three. Okay. The second thing is I do think it's a bad idea. For two reasons. One is the whole question of incentives. One of my 6 children is working in a, 2 or 3 years out of Stanford now, is working in a Silicon Valley startup company, and he's being paid in the low 30s. And we figured out one day that he's now in the 50% marginal tax bracket. And I think what would happen under the Clinton plan, or the kind of plan you're talking about, is he'd probably be up in the 62 to 65% marginal tax bracket before long. Now, I could tell you sometime at greater length about a couple of my trips to Scandinavia, but let me just give you one thing that really made a big impression on me in visiting Scandinavia. The Swedish Institute for Health Economics invited me to come over and look over the whole thing, and a surgeon who was chief of emergency medicine at Lund University was extraordinarily frank with me, told me exactly how much he was being paid, the other doctors are being paid, and so forth, how the whole thing worked, the tax rates, and so forth. And he said, you know, Dr. Enthoven, doctors in Sweden are not like doctors in America. We're more like nurses. He said, if the pipes break at my home, I don't call the plumber. I go and fix them myself. Now, why does he go and fix them himself? Because he'd have to work about 5 hours to clear enough money, net after tax, to pay the plumber for 1 hour. And
College
the problem with
professors are in the same situation,
all right.
by the way, vis-a-vis plumbers these days.
All right, and the high marginal tax rates interferes with the division of labor, which is an important part of the efficiency of our economy. And I think that in this particular circumstance, it's bad for the surgery and it's bad for the plumbing.
The empirical evidence from Germany just doesn't support that argument, Alan, because there you have the system financed by marginal payroll tax rates at about 10%. The marginal taxation burden in Germany is substantially higher than the United States, and there's no impact on the division of labor, no evidence that they're substantially handicapped by this. I mean, it's you know, one anecdote doesn't make systematic evidence here.
How many net new jobs has Europe created in the last 15 years?
Do you know what the unemployment rate is in Germany?
Unemployment rate numbers are bogus in the European. They make it, that, to me, the real question is, how many new jobs have they created? And the answer is basically 0. And I think to say that there aren't job issues involved in the way they choose to finance a lot of their social programs is simply not real.
Well, we could have an interesting argument about what's happened to the convergence between European and American gross domestic product per capita, and the fact that over the last 20 years, the gap between European and American gross domestic product per capita has closed substantially, so that however badly they've done economically, we've done worse, Charlie. So I think we could play with the numbers, but I'm interested in what you
measurement.
This might be our next forum.
Yeah, I'm interested in what you think about a tax-supported plan.
Okay, the third thing I'd say on the merits, why I think it's a bad idea, is go back to what I learned in the Pentagon in 8 hard years there as point man for Secretary of Defense McNamara on trying to bring cost effectiveness to the Pentagon, and the fact that the ideal weapon system is built in 435 congressional districts. In Vice President Gore's report to the American people on government last year, the National Performance Review, he said the average American believes that the federal government wastes 48 cents on the dollar. And I think he's right. I experienced it, you know, trying to combat that. And so I think one of the problems with tax revenues is they go to the politicians who then respond to all kinds of you know, requests for this, that, and the other thing, and pretty soon it all gets spent on very non-economic.
You know, it's amazing because the Canadian system, which is financed by tax revenues, is usually criticized for being overly austere. I mean, it just amuses me that people switch to say the tax system is too austere or not austere enough, depending upon which side of the issue they're on.
I don't think it's so much austerity. It's where do they build the hospitals? Is it this politician's district versus that one, or do they build them where they're needed?
One last question.
Hi, thank you very much for a very outstanding discussion. I'm a physician at Mass General Hospital. My name is David Morris, one of the only physicians that I see around here, at least. My question revolves around the issue of tort reform, which didn't really come up in anyone's discussion. Measurements of outcome are very difficult, and as a practicing physician, I often am puzzled as to whether a specific treatment is going to help or not. And outcome measurements are so imprecise that I can't necessarily rely on the literature. So my decision about what's going to fit for a certain patient may well not fit with what an HMO would dictate is most cost effective. On the one hand, I have my professional obligation to the patient to try to give them the best care that I can. Some have argued that the reason that tort reform hasn't been made a more major part of the discussion is that it's the patient's ability to protect their own level of care. In other words, that they have recourse to a system that doesn't cover them adequately. As a physician, I feel like if this came into play, I would be put in a difficult position of trying to choose between my patient and my HMO, and I'm wondering about shifting the liability then to the insurer or the health plan rather than the individual physician if certain treatment plans are dictated.
Well, I think that the tort system, in fact, has a lot of inefficiency and unfairness, and that it would be appropriate to reform it. I think among the things, so much of the money goes to the process itself, 60 to 80% goes into the legal processes and so forth, and I think it would be better to make more reliance on arbitration and alternative dispute resolution. And also I think we've had in California what we call MICRA, the Medical Injury Compensation Reform Act, which has limited pain and suffering to $250,000 damages, and otherwise limited the recoveries, and that has, the doctors out there tell me they feel a whole lot better about the situation under that circumstance because it limits the big prize that the tort lawyer goes after to try to make $1 million as his share of the recovery. I think that such things as arbitration with the idea that the results of the arbitration, if the plaintiff wants to pursue the case in court, that the results of the arbitration would be admissible in court, and that the English rule would apply. That is, if you take the arbitration to court and the jury doesn't agree with you, then you have to pay the defense costs. I think we could adjust the incentives and get a less inefficient, less inequitable system.
There's also another point on that, which is Joe Newhouse, who's one of yours, did a huge study on the New York medical system, and basically what he was studying was maloccurrence versus bad practice, and how patients under those circumstances were rewarded or not, relying on a tort-based system to get from here to there. And the conclusion from his study was, which was unbelievably thorough and absolutely gigantic sample size, was that tort-based mechanisms to reimburse patients for bad medical practice simply did a terrible job of appropriately paying people who had received substandard care, and did a relatively decent job, relatively speaking, rewarding people who simply had bad outcomes. And to some extent it was a function of how good your lawyer was and what kind of case you had. And I think his recommendation, which was basically that you really needed to get away from a tort-based system and move to, frankly, some kind of a no fault on that, was actually the best recommendation of all.
And on that note, I'd like to thank you, Alan Enthoven, Deborah Stone, and Charlie Baker.